and welcome to Your Health. I'm Jim Thompson. Our program presented by Greenwich Hospital, and the subject today, the stroke program at Greenwich Hospital. My special guest is Dr. Frederick Nahm, PhD, neurologist, director of Greenwich Hospital's stroke program. Medical school at the University of Michigan Medical School, internship at Mount Zion Hospital, residency and fellowship at Beth Israel Deaconess Medical Center, and board certification neurology and neurophysiology. Dr. Nahm, welcome. Thank you for coming in.
Nice to be here today.
It's a lot to talk about here today, as always on our programs, but I've got to say that the word stroke, I guess just the thought of that is extremely frightening to most people when they hear that. What is a stroke? And as I asked you that, I know it's called a brain attack. Tell us about that, please.
Yeah, a stroke is something that happens to the brain and something that happens to your person, to your function, to your ability to navigate in life. So, the first is really an objective term. You can see something in the brain on imaging studies, or you experience something in terms of symptoms, which we'll be talking about. Mm-hmm. So again, a stroke is typically an acute, rather fast onset change in your neurological status, like your ability to talk or walk or speak, see. So a change in your function. And we use the term brain attack because people understand what a heart attack is. People understand that if they have pain in their chest, well, that could be a heart attack, and they know that they have to do something about that. Yeah. So the word stroke is a little bit less strong than that. So the Brain Attack Coalition said, well, let's use something similar to heart attack. Let's call it a brain attack, because then people will know that they have to do something about it in a kind of expeditious fashion.
Yeah. Yeah. Now, over the years, and I've said this on this series of programs right now, that people will think, well, a heart attack, yeah, it's what I ate last night, it's indigestion, or I'll take a bicarbonate of soda or something. Or I'll drive myself to the hospital. Don't do it. Call 911, get there. And with a heart attack, as you know, for the most part, we get the pains. Sometimes you don't, but for the most part of that. With a stroke, just as important, I imagine, time-wise, the minute something's going wrong, to call 911. But what is that something that goes wrong, and what should families watch for in maybe, and we'll talk about that later, if it's an elderly person or whatever age limit that a stroke will usually attack or cause a brain attack, what do they look for?
Right.
What does a person look for even?
Yeah. Well, that's one of the biggest problems in educating people about brain attack or stroke, is that the symptoms can be very diffuse. They can be, again, they can affect your motor system. You could be weak. You could have weakness of the leg or weakness of the arm. You could have sensory symptoms, numbness or tingling. You can have visual changes, blurred vision or double vision or lack of vision. You could have headaches. You could have vertigo or spinning. You can have balance problems where you're walking and your walking is off, and some people say, somebody said I looked like I was drunk, but of course they weren't. You were having a stroke. Yeah. So the symptoms are very diverse, and that's hard to kind of get people to understand, because you have to have a high index of suspicion that something's wrong. And the key is that the acuity of it. Something that happens out of the blue. You're walking along, bam, you get weakness acutely. Your vision goes, your speech goes, your language, you're talking mid-sentence and all of a sudden your language stops and then comes out gibberish. So the acuity of it, as well as the type of symptom, is important in terms of recognizing, both for the people experiencing it as well as family members. And a lot of, I can't tell you how many stories there are of people who woke up and were fine and they were having breakfast and they had these symptoms and they said, well, let me go back to bed and see if I can sleep it off. Mm-hmm. Or the family says maybe he was just tired. So people in general tend to discount that, whereas, again, to go back to the question about the brain attack, when you have pain in your chest, most people jump to action.
Sure.
Right? So we want people to do that too for the stroke. If is it a change in one of these kind of systems, neurological systems, you want to jump to action. You want to activate 911. You want to get on it as fast as possible. And that has really changed kind of treatment
Yeah.
in the past decade, getting people to recognize that they're having something and getting them to the hospital.
And the work is being done, for example, as we know, in the ambulance. You're getting help immediately from the people in the ambulance, and aspirin with a heart attack and all of that. When a stroke is coming on or ongoing as that person is being taken to the hospital, what's being done for them?
That's a great question. And why do you want to call 911? Why do you want the emergency medical technicians to come there, even if you live 2 minutes away?
Yeah.
And you think you can drive to the hospital faster than the emergency medical technicians can get there. And the reason for that is they do a lot of pre-hospital workup. So they get there, in our town, within 5 minutes, basically, they can get to your address, wherever you are. And they do an initial set of vitals, which is very important. They can get an electrocardiogram on site in the field. They can see how well your heart is working. They can do an initial stroke assessment. And there's a number of tools that we use kind of to gauge, how severe things are at the beginning. And they can phone all that information into the hospital so that the emergency room has an idea of what's coming. And at the hospital, we have a stroke alert system in place. So sometimes we will get an alert that a stroke is coming in even before the patient comes there, which means we can prime the system. Everything can be ready in the hospital so that when the patient does come, we're already ready and primed to kind of get things going. Mostly is managing vitals, checking fluid status, blood pressure, heart rate, again, the electrocardiogram, the heart rhythm.
Yeah.
And just, again, that pre-admission is extremely important, and again, has changed how fast we can do things in the hospital. Because if we know what's coming, and we have an initial set of parameters to work with, then the work is already underway by the time you get there.
Now, when the patient is brought in, the work being done then by the doctor, everybody who's concerned with that, is that the primary factor of how that stroke will be handled as far as the severity of it? Those things that you said, maybe you'll be left with one side that doesn't quite work right, or your speech or your vision, what have you. Is that dependent on really how fast you can get to the meat of the stroke, if you will?
Yeah, absolutely, right. Time is key, or time is brain, we like to say. Because every second when you're having a stroke, there are millions of brain cells that are at danger. So the faster you get to the hospital, the faster you can administer the different therapeutics, and there are some new therapeutics available that can kind of halt the progression of the stroke. So the faster you get there, then the more brain you can save. Because once the brain tissue is lost, you can't regenerate that. That tissue is lost, and different parts of the brain can take over some of those processes. But you really want to salvage and save as much brain as you can initially. And the key to that is getting to the hospital as fast as you can.